Good afternoon, everyone. Welcome to today's Complex Pediatrics Project Echo Clinic. We'll be hearing from Dr. Fernapfel on her background and how behavioral analysts can help support pediatricians and that sort of thing. I think we'll start off with introductions. So I'm Troy Jorgensen. I'm the program coordinator here at Echo Nevada. Then we'll go to Andrea Forsyth. Andrea, go ahead. We should be able to hear you. Oh.
Hi, I'm Andrea Forsyth, and I am one of Bridget's supervisees for the BCBA program.
Great to have you today. Dr. Levy.
Hi, excuse me. Hi, I'm Dr. Levy. I'm an associate medical director here at Project Echo.
Meg Floyd.
I am a MS3 who's on pediatric rotation right now.
Great to have you today.
Thanks for having us.
Nelson Quezada. Nelson, are you there? Can you hear us? Nelson is another MS3.
Oh yeah, I'm here. Can you guys hear me?
Yeah, go ahead.
Oh yeah, so Nelson, I'm another MS3 on my outpatient pediatric rotation.
Great, wonderful to have you today. And then Jay Holt, joined by telephone. Could you take yourself off mute? Go ahead.
Hi, my name is Jonathan Holt, and I'm a MS3 as well. I'm joined here by George as well. He's also an MS3. Hi.
Great to have you all today. And then Caitlin Hymas. Caitlin, go ahead. I think we should be able to hear you. Okay, maybe no audio for Caitlin. And then, yeah, Dr. Fernapfel.
Hi, I'm Bridget Fernapfel. I'm a board-certified behavior analyst here at the University of Nevada, Reno. That kind of includes a lot, but I'm primarily housed in the Nevada Center for Excellence in Disabilities, where I service quite a wide range of projects. As you see, Andrea is here joining me. So I supervise graduate students here and train them in behavior analysis. I teach classes as assigned in the special education department or the behavior analysis department sometimes. I work on various projects, one being teacher training. We're finishing up one of the grants that we've had here for a number of years, which has put 21 board certified behavior analysts throughout Nevada schools. And so I'm responsible for all their training and supervision hours, as well as some coursework. I also work on projects with PBS Nevada, so it's our positive behavior interventions. And we'll get into a little bit what that is later on in the presentation, but we work with anywhere from toilet training to feeding issues to just problem behavior in the schools or the home setting. So kind of a wide range there. And I also participate, I did participate in our school-based mental health echo that just kind of finished up our inaugural year. So I sat on the expert panel for that. And then I also am part of our Nevada Aging Project, which services individuals with neurocognitive disorders, primarily dementia related to Alzheimer's, that sort of thing, and training their caregivers in behavioral approaches to kind of lessen some of those symptoms that they're experiencing with their loved ones. That's kind of me in a nutshell here at UNR. I have a wide range of experience from the past, ranging from early intervention with autism, school-based services, neuropsychological services, clinical psych, which is a conversation for another time, but we can go ahead and start, Troy, because I think we kind of have a full presentation here for you all. So really, Troy asked me to come and speak with you all today to kind of talk about potential areas where pediatricians can really collaborate with a behavior analyst, especially in behavioral pediatrics. And just a caveat, I am married to an emergency physician, so I kind of have a little bit more passion in regards to really reaching out and kind of forming collaborative relationships with a medical professional. So I do know a little bit about, the medical background, and I think that helps me somewhat in this area. So There, are we going? Troy, it's not dancing for me. Oh, there it goes. Okay, so just an outline briefly about what we'll talk about today. The first is just reviewing some common problems in behavioral pediatrics. I wanted to give you a little background just really on what behavior analysis is for those of you who might not be as aware about it, and then kind of what a behavior analyst is, just in a little nutshell. We'll talk a lot about function of problem behavior and what we mean by that when we talk about that in terms of behavior analytic treatments. We'll look at some just really quick snapshot treatments for some of the common problems that you are likely to see in pediatrics, and then we'll have some time for summary and questions. And feel free to stop me at any point within this presentation if you have questions or whatever it may be. So there have been quite a few surveys conducted by way of behavior analysts or clinical psychologists who are kind of questioning pediatricians in terms of the most common problems that are reported. And obviously this list is those physiological kinds of things, right? Ear infections, upper respiratory infections, asthma, injuries, fevers, those sorts of things that are treated by way of medical interventions. However, when pediatricians also provide this feedback, there's this whole category that is really behavior-based problems. And depending on what author we're looking at, it's reported to be about 56 to 58% of well-child visits that have to do with child rearing or behavior management issues, as we would classify them. So these are things like oppositional behaviors, not listening to their parents, sleep and bedtime problems, attention deficit and hyperactivity disorder or symptoms that are related thereto, eating problems. These are picky eaters or children who refuse to eat altogether, school behavior problems, infant management, recurrent pains, chronic headaches, chronic just aches and pains, that sort of thing. Toilet training always is a big one, and then enuresis and encopresis. When asked what the most challenging problems of that list are, pediatricians usually report these. So they'll talk about the oppositional behaviors, ADHD, a lot of problems related to school or the environment, the educational context, encopresis, recurrent pain, depression, eating problems, delinquency, which we could probably also relate to a school problem, enuresis, or sibling and peer relation problems. And of this list, these are all things that behavior analysts work with, and we have empirically validated treatments for pretty much everything that's listed here. Which brings me to really what behavior analysis is when we talk about what we can do in the realm of pediatrics. We seek to really design and what we do is we are designed to identify the purpose, or what we call the function, that a behavior will serve for a specific child. And we develop interventions that are then based off on preventing problems from occurring altogether. We look at teaching replacement skills that are more appropriate than the problem behavior that is being exhibited. And we teach how to respond effectively to either the problem behavior or whatever replacement behavior that we are going to aim to give that child. Our goal is really to improve behavior and enhance the quality of life for both the child or the patient and their family. Now, that being said, a behavior analyst really can be considered a behavioral health professional. We are credentialed through a national organization. It's called the Behavior Analysis Certification Board, or our BACB. We also do carry licensure in some states, not all states. Nevada is one where you can carry a license here, which will allow us to gain access to Medicaid and insurance, primarily for children with autism and developmental disabilities, but we're working on that. We are commonly referred to as a BCBA. This is our master's level practitioner, or a BCBAD, which is our doctoral level practitioner. So if you have patients that present in the office and they're talking, and I could really say children with autism, so children who are on the spectrum, oftentimes you'll hear their parents referring to their BCBA, and that's us. That's what we do. It's just the acronym that kind of flows out better than saying behavior analyst. So now that you kind of know, like, kind of what we look at, kind of who we are, what I really want to talk about is how we address and really look at behavior. So, and again, we call this the function. And so I want to show you just the little, are you going to do this, Troy? Just a little video, and we'll look at this a few times, but and this is Super Nanny. So I don't know if many of you are familiar with Super Nanny, but she's wonderful. So you'll get to meet her. But a caveat about Super Nanny, this show probably came out, gosh, I want to say like 10 or 15 years ago. So Jo Frost is actually the super nanny. She's an actress, but behind the scenes, she's coached by behavior analysts. Some pretty highly regarded behavior analysts were consultants for this show. And so what I want you to pay attention, we're just going to watch this and just kind of see what's going on. Look at the problem behaviors or what you might consider problem behaviors. And then think to yourself, if this mom were to present in your office, think about the things that she might be reporting to you based off of what you're seeing, okay? Go ahead, Troy.
Kate was on the sofa downstairs and she was banging the bowls, hoping that it would get Mum's attention because she was busy dealing with the boys.
No! Sweetie, here. Where's the heart? You can take a turn and Nika takes a turn. No! No hitting! That is not nice, Nicholas. Oh, Teddy, can you give it a rest, hon, please? Let's play cars. Kate has foot cramps, so I have to rub her feet.
It didn't look like Kate was in that much pain. She looked bored. I think these foot cramps might be more about getting Mum's attention.
All right? Mama. Mommy's not going to drop what she's doing every time your feet hurt. Kate, rub your own feet.
Why do you think she's crying now?
Because of her foot cramps. She has them all the time.
I'm going to go upstairs and just see Kate. It was really sad. Kate ran upstairs, absolutely sobbing, and I needed to find out what the heart of this issue was.
Okay, you can stop it there, Troy, if you want. Okay. And then if we can go back. So just kind of briefly, what did you all see there? What were some of the problem behaviors that this mother might come and report to you?
Yeah, please feel free to unmute yourself or write in on that chat box.
There was some violence when the one kid hit the other one with the block.
Mm-hmm. And so if you think back to that list, that's some of that probably sibling rivalry or sibling issues, right? That is probably commonly reported. What else? What about the daughter? What was she complaining of?
I mean, the foot cramps were probably just a response for her to get her mother's attention. She probably just felt neglected, which is probably totally understandable if you have multiple children that are taking up the mother's attention.
Right. Exactly. So those foot cramps. However, I mean, you guys are watching this from a different lens, right? You're actually watching what's going on in the home context. However, if mom presented in your office, she might give you a completely different story, right? About kind of what the etiology of those foot cramps might be based off her beliefs and all of that. So we'll kind of work through this example a little bit. So when we talk about function, what we really look at is when we're assessing a problem behavior, we look really closely at 3 areas. So we want to look at what happens immediately prior to the behavior, and this is usually immediately before. There are some instances where there could be things that happened, with a larger temporal gap, but usually we're looking at what happens right before the problem behavior occurs, what the behavior itself looks like, and the reason we look at kind of it more topographically is so we can measure it a little bit more efficiently. And then we want to look at what happens immediately after the behavior. So really what is serving to, increase the likelihood that we're going to see this behavior happen again. Okay. And so in order to determine function, again, the ABCs really help us in terms of looking at what we would call those antecedent intervention or those antecedent conditions. So what happens immediately before the behavior? This gives us information about what we could potentially do in that setting, whether it's the home, whether it's school, whatever it may be, that we could modify in order to prevent the behavior from occurring in the first place. So, and then again, it lets us know what this behavior looks like. And that really just allows us to collect more accurate data, look at the frequency, the intensity, and all these other various dimensions of behavior that will provide us with a little bit more information as far as if our interventions are effective. So if we know what we're looking at and we're going to intervene on this behavior, then we know whether or not it's effectively reducing or increasing, depending on what we want to see. And then we are also to see again and what immediately follows that behavior. And this gives us information about how we can respond or teach parents or teachers or, you know, whoever it is that's interacting with this student or this patient, how to respond more effectively to that problem behavior in the future. Again, to get those, the behavior change that we're looking for. So I kind of want to, we can going back to this video. We don't have to watch it again, Troy, unless you guys all really want to. We talked a little bit about the problem behaviors that we saw. So you saw some violence or some aggression, right? By way of those, they're twins. So the two little boys they hit each other, or one hit the other. And then we saw these foot cramps. So actually, Troy, let's go back. Let's watch, let's pay attention first to the little episode with the brothers. And I want you guys to look at what happens immediately before and then what happens after, okay?
I was on the sofa downstairs and she was banging the bowls, hoping that it would get Mum's attention because she was busy dealing with the boys.
No! Sweetie, here. Here's the heart. You can take a turn and Nika takes a turn. No! No hitting! That is not nice, Nicholas. Oh, Teddy, can you give it a rest, hon, please?
Okay, so what did you guys see? If we're talking just about those brothers' aggression, what did you see happen immediately before that hit? So the sister was banging pots, right? Oh, that might be old. So,
no, that was one that just came in. Yeah.
Was that, okay.
Yeah.
So the sister was banging pots and then it switched over very quickly. Those boys are playing with a shape sorter, right? And you heard some stuff. What did you hear the mom saying? There was something about turn taking that like one of them had taken. Andrea, do you want to chime in here?
She was saying, no, she was giving them attention, and then like there was head rubs and after the hit.
Right, so that was after. And then before, it looked like there was this issue, which is, I mean, those boys look little, they're probably no more than 2, but they were fighting over that shape sorter, right? So there's some issue there where there's not some real good, real solid like social interaction skills with turn taking. And so you do hear the mom saying, no, we have to share, you got to give it to your brother. And so we could look at that as what we would call that as like access to a tangible or something. So the one brother took the shape sorter away from the other one, and by way of that, the other brother hit him to get it back. Does that make sense? So immediately happened before. And then as a result of that hit, the mother did what?
She reprimanded her other child, saying don't do that, essentially.
Exactly. So she reprimanded them, and we would just consider that attention. She's giving them attention, and attention can be either positive or negative. And in this instance, she's saying no, and there's some sort of corrective statement, right? So that would be our basic ABC. So the antecedent is the brother takes the toy, the other brother hits him to get the toy back, we would assume, and then as a result, mom gives them attention. Okay. Now let's take a look at the foot cramp, Troy, if you want to go back to that video again. Sorry.
Please, let's play cars. Kate has foot cramps, so I have to rub her feet.
It didn't look like Kate was in that much pain. She looked bored. I think these foot cramps might be more about getting Mum's attention.
How are we gonna play? All right? Mama. Mommy's not gonna drop what she's doing every time your feet hurt.
Thank you. Okay, so what are you guys seeing there?
So mom's dealing with one of the 2 brothers, and then she's having foot pain in the middle of that going on.
Right, and then what does mom do as a result of her saying her foot hurts?
Stops doing what she's doing and rubs her feet.
Right, so she doesn't have mom's attention. She complains of these foot cramps, and then she gets mom's attention. Okay, yeah. So that's why we're talking, when we talk about those ABCs, those are those immediate things that are present in the environment that we would look at as far as what's maintaining this behavior. And then later in the video, before she runs up, or after the little girl leaves, and the nanny actually asks mom, why do you think she ran out of the room? Mom's response was, because her foot hurts. So in mom's mind, she's still thinking that my daughter's experiencing these foot cramps because she's not even looking at kind of what's going on in the environment as far as why those things would be happening. Okay, I hope those examples are clear. Please let me know if they're not.
I think they are.
Okay, thank you, Meg. All right, can we go back to the PowerPoint, Troy? Okay, so that's, and again, so when we're looking through the ABCs, this is how we're gonna break down behavior analytically, every behavior that we look at, whether it's aggression, some sort of, you know, property destruction, social isolation, those sorts of things, okay? It's a minute for me to go. And what these ABCs really help us do is they lead us to what the function of this behavior is. And you guys are kind of already getting the hang of this. But when we talk about function, behavior typically occurs to produce 4 main outcomes. The first is attention. And so we saw that a lot in this video. The boys are engaging in problem behavior, they get attention. Daughter's complaining of these foot cramps, she gets attention. We also have access to tangibles. So we saw that with the boys. One removed the tangible, the other one hit him to get the shape sorter back. Another classic example of this is the child throwing the tantrum in the candy aisle at the grocery store. I'm sure everybody's seen this happen, or the toy aisle, right? Kids screaming and crying because they want to leave the store with a candy bar or a toy. And typically, what do parents do?
I know my mom would say, "You ain't getting that." So, you know,
right.
She'd probably like slap me or something like that. I'm just kidding. But
Right. No, sometimes, right? We lived in a different day and age. But often the children actually get those items. So it increases the likelihood they're going to cry and tantrum the next time they're in the candy bar aisle or the toy aisle. We also engage in behavior to escape from something that's really undesirable or something we don't want to be around. This is where we see a lot of this in schools, actually. Children who have difficulties with math or English, that's when they will start eloping, or we can talk about the delinquency here. They may ditch school because they don't want to go to math or they don't want to go to English, those sorts of things. So we're doing things to get away from something we don't like, or sensory stimulation. And this is where a lot of the stereotypical behaviors come in. So the hand flapping, the spinning, those sorts of things. Children engage in those behaviors to gain some sort of sensory input, you know, from their environment. And we're not going to go back to this because you guys pretty much nailed that those behaviors were attention maintained. So I hope that's very clear. I won't have you watch that video again. So I wanted to just refresh your minds going back to that list that is these concerns that are typically reported by pediatricians by way of oppositional behaviors, ADHD, school behaviors, all these sorts of things, and kind of begin to shift you to thinking maybe some of these things, if we look at it in more of this ABC kind of context, how we could begin to look at them a little bit differently than maybe, you know, just the medical address. Although I will say a caveat here too, before we intervene on any behavior, and Andrea can speak to this, the first thing I train any of my supervisees to do is a medical rule out. That's really important, especially with eating problems. You want to make sure that there's not something physiological going on. Complaints of recurrent pain. If everything comes out physiologically sound and there's no reason for this behavior to be occurring, then we would look into the environmental context and see what's really going on. When we talk about function as well, we also talk about how it's really important when we are selecting a problem, or when there is a problem behavior and we're selecting a behavior to take place of that problem behavior that is going to be more appropriate, we want to make sure that whatever it is that we're selecting matches the function of what that problem behavior is, so the child still has a way to gain access to that outcome, just in a more appropriate manner. So for example, in a classroom context, if a parent comes to us and says, you know, my child's not completing math, they're throwing a tantrum all the time in math class, they won't do anything, they won't even complete a math problem, what we would do is teach the child a more appropriate way to get out of math or to request a break from math versus tantruming. So we might give this child like a break card, and they're able to exchange that break card or raise their hand and ask their teacher for 5 minutes or something like that. That way they're still able to escape whatever it is that is unpreferred to them at that time. But we're no longer going to reinforce that tantruming. Okay, so we want to make sure that those things serve the same function. Otherwise, our interventions aren't likely to maintain or actually produce any outcome that we would want. Troy asked me to speak a little bit in specifics for you all about some certain issues that you may see. The first was medical noncompliance, and as a behavior analyst, how we would kind of address or intervene with these sorts of things. And I'm sure you've all seen this, right? And I think especially to like pediatric dental procedures, or you think about like blood draws or things like that, things where children are going to just engage in these avoidance behaviors immediately. They walk into a dentist's office and they, that chair is really scary. They see all these sharp instruments, and you can imagine what's going through their head, like, what are they going to poke me with? What are they going to do? So how is it that we would even begin to intervene or help a child get through these things? Typically what we would do are antecedent interventions. So that A part of our diagram there, we would look at some sort of desensitization or stimulus fading. And by this, a lot of this is done with children with disabilities to kind of get them ready for that setting, or children who have kind of chronic illnesses to get them ready for procedures. So what we would do is, and I'm just going to use the dentist for an example, a child comes in, we would have them just walk into the exam room. All they have to do is stand in there. We're just going to let them see it, get used to the lights, the sounds, that sort of thing. We're going to desensitize them to the setting as a whole. Then the next session, they might come in and actually sit in the chair for 5 minutes, and then they earn their reinforcer for sitting in the chair. And then it gradually becomes more and more complex as they're being compliant with the tasks that we're asking them to do. So if they're compliant with staying in the room, we're going to step it up. When they're compliant with sitting in that chair for 5 minutes, we're going to step it up. Maybe the next step is having them sit closer to the tools and the instruments, or actually picking them up and looking at them, that sort of thing, and gradually increasing our expectations for the children as we continue up that hierarchy. We also use a lot of modeling with children. So I can give an example. It may not be the best example because I think it actually backfired on me, but my boys just had their flu shots. And I thought that if I had my 4-year-old go first, that my 1.5-year-old would be much more likely to be compliant with the shot because he would see his brother doing it. And so the 4-year-old went, and he was fine. They're really good. He didn't resist it, but he did say, no, 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 while he was getting the shot. I mean, that was it. So then when the 1.5-year-old went, he was fine. He was compliant, but he did also say, no, 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 no. So, not ideal. Maybe next time I'll switch those roles and have the younger kid go first. But the point is, if there's a more appropriate model that we can use and use that child to go first and complete that procedure, then the other child is more likely to do it as well. You can also do a lot of video modeling. That's very common these days. It's very empirically validated, where we're actually recording other children who are compliant with those procedures. So blood draw, for example, you would record a child going through a blood draw, completing it compliantly, and play that for the child who's not compliant before they go in to kind of prepare them for what's going to happen. And you walk them through it, you model some other things, and then when they're calm and collected and viewing that video, they earn access to their reinforcer. And again, eventually you're going to step that up. We're not just going to let them watch the video, but the video is more of an antecedent intervention to prepare them for what might be coming. We do use distraction. The fancy word for this is non-contingent reinforcement. My husband actually in the ER, I don't know what they call it, but they have this like light thing. It looks like a squid with all these like crazy lights, and they will pull that into the room for children. So the children will stare at and they actually call it their distractor. The kids will stare at that, and then they're able to kind of like quickly get through some procedures. Maybe they're quickly able to do a blood draw or, get an IV in or something like that while the child's distracted by this other thing. So we will do that. iPads are also really good for that. Andrea can probably attest to that. We use those a lot. We also would suggest using something like non-contingent escape. And this is where the child is just allowed breaks throughout the procedure. And it doesn't necessarily have to follow compliance, but it may just be more of a timer-based kind of thing. But you go in for 3 minutes, they're pretty good for 3 minutes, and then they get a break. Then you're going to go back and finish what you're doing, and then they'll get a break. And then, so on and so forth until whatever procedure it is that you want completed will be completed. Behavioral momentum is another strategy that's utilized frequently. This is where we use something that the child is more likely to comply with and build it up, and then follow that with something that they're less likely to comply with. So for example, a good example for this would be like eating habits. We would say, you can eat the pudding and then you're going to eat the pea. So eat the pudding, eat the pudding, eat the pudding, then we're going to throw a pea in there. And because they've had all that success of eating the pudding, they're more likely to stick that pea in their mouth. Okay, so we would use something like that. And then simulation training, of course. We could always simulate some sort of task or procedure and walk the child through it that way. There are also consequence-based strategies, so things that we look for, on that C end of our ABCs. And really this revolves around differential reinforcement. And so what we would do is if, let's say the child really, again, if it's like a dental procedure and they won't even, let the instruments be placed in their mouth or anything like that, or they're turning their head, what we would do is set a period of time where if the child did not turn their head, or if they actually let us put the instruments in their mouth, they would then earn access to a reinforcer. And we're only going to provide reinforcement for that compliance. And we're no longer going to attend for any of turning or mouth closing or refusal to let us do any of these other things. We can also just back it down to compliance with tasks. So if you walk in and say, oh, we gotta, get a flu shot today, and the child lets you, stick the needle in and you successfully are able to give that flu shot, then they earn their reinforcer. And then also negative reinforcement. So you could, this procedure would look more something like, we have to do, this list of things. And if the child or the patient complies with one task, then they get out of having to do the other. So we're removing the likelihood that they're going to come into contact with these other aversive things because they're going to comply with this one thing. The last ditch effort that we would probably try, and this is used a lot also with food selectivity, is what we would call escape extinction. And this is really where we just continue to present the task until the child complies with it. Again, it's kind of one of the last ditch things that we use because it takes a lot of time. It's really aversive for the kids, and often, especially with like medical procedures and things like that, we really want to be sensitive to not making the situation more aversive than it might already be. And so by continuing to present that task, we might actually take a couple steps backwards with that patient. The next topic that Troy kind of wanted us to briefly touch on was how we go about motivating patients and parents. And the first thing that we always do with our consumers or our clients is preference or reinforcer assessments. This is huge because you're not going to get a child or a patient to do something for you if they're not going to get anything out of it typically. And so we would ask with our older kids, we typically just ask them like, you got to go have a blood draw. What would you like to do? What would you like to get for actually going and having this blood draw and complying with this blood draw? And older children without disabilities are really able to answer these questions, and that's great. There are ways to conduct preference and reinforcer assessments with children with disabilities or, with language disorders. And, oftentimes that just comes down to having a basket of like really cool things, and you just hold them out and you say pick one, and whatever the child kind of grabs and gravitates towards, you would assume that that's probably what they want. And so if they comply with your task, then they earn access to those toys. And it doesn't just have to be one toy. I mean, if the child wants everything in that basket and they're going to let you do a blood draw or give them a shot, I would let them have the entire basket, right? To really just praise the child for kind of complying with those tasks. We also focus a lot on rapport building with our consumers and establishing ourselves as reinforcers. And I know this is challenging because oftentimes, especially in the pediatric setting, your time limits are so short with patients. So you're in there for maybe 15, 20, 30 minutes tops. So 30 minutes is probably, kind of generous if I'm thinking back to my kids' pediatricians. And so you really have to kind of make that time the most for yourself and really establish yourself as a reinforcer with these kids and pair yourselves with things that that they like. So that's where like the stickers come in and the toys come in, and really praising the children when they're in your office and things like that to increase the likelihood that they're going to really like you. And then because they like you, then they're going to be more compliant for you. And then what we also talk about with parents, and this is another really important thing to consider, is when we talk about selection for behavior change, like the target that parents want. So parents might come into you and say, you know, I need help with toilet training. Well, toilet training is a huge task. But when you have, you know, your 20 minutes in there with the patient, you might notice that not only do they need help with some toilet training, but there's some compliance issues, like this child's not really listening to their parents, that sort of thing. And so what we would kind of talk through with the parents in a way that fits their worldview, and we'll talk about that a little bit in a minute, is selecting a behavior that, one, occurs frequently enough that they're going to actually the child will be able to come into contact with whatever consequence it is for engaging in that behavior. And then also one that is meaningful to the parent. So if the parent sees that there's behavior change in my child, then they're more likely to continue doing with what they're doing. I hope that's clear. So I could give you an example for a student that I worked with. He wasn't bowel trained. He was a 5-year-old who wasn't bowel trained, but he also wasn't urine trained either. And so obviously we know that like we don't have bowel movements nearly as often as we, you know, urinate on the toilet. So when we're kind of going to those two things, and I'm talking to the parents, and their big thing was they just didn't want to change, you know, they didn't want to change the bowel movement diaper. That was highly aversive to them. And I understood that. But we had a higher chance of catching the child urinating than we did, you know, having a bowel movement. So we had to intervene here first, even though this is what meant more to the parents. But because the parents saw the behavior change with the urination, we were then, we kind of then sold ourselves to them, and we helped them there. And then we were able to go ahead and intervene on the bowel movements as well. So sometimes it's not always what the parents want to hear first, but that's where we have to start. You have to have a starting point. And then again, to frame the intervention to fit the parent's worldview. So if you think about this mom, you know, with this little girl with the foot cramps, and she's coming into you and she's saying, oh, there's something wrong with her, her feet are hurting, how you would address that by way of what she's telling you and what's meaningful to her, rather than just immediately correcting her and say, oh, no, that's because you're not attending to it, you know, you're not giving her as much attention as the other boys. So really being mindful about how you're speaking with the parents and selling your interventions for behavior change to them. The last thing that we really, really, really stress with parents and our patients is consistency. So, and this is probably, if you leave here with anything other than the function of behavior, leave with this. Behavior interventions have to be implemented consistently to see the effects. So sometimes too, we always have to warn parents as well, like, especially if it's like tantrumy behavior or noncompliance, whatever it might be. I always tell my parents, expect this to get worse before it gets better. Because then typically if a parent goes home and, you know, we're telling them we got to ignore that, you know, giving them these various interventions to use with their children, the second you ignore a child with an intention maintained behavior, that behavior is going to skyrocket. And so you got to prepare parents for that, because if parents see that and they're not prepared, they're automatically going to think, oh my God, like I'm trying to ignore this behavior and it's only getting worse, right? That's just our automatic response to what would happen. So we try to prepare them for that. Like, this is going to get worse. And you have to be consistent. So I know it's hard. I know it's going to get worse, but the more you're consistent, then you're going to see this behavior change. Okay. Any questions so far? Other than what that sensory tool is. I like how you call it multisensory, because I just call it the distractor. I'll correct my husband on that, actually. Yeah, dementia. And I know they use it with their a lot of their adolescents that come in when they've been experimenting with things. Put it that way. It works well with that population too. The next thing I kind of wanted to walk through is toileting. This is one of the big areas that we get asked about for help with all the time. And there are a multitude of ways you can toilet train a child, but there is one very successful method, and it typically, if the child is ready to engage in toilet training, this can be successfully implemented and completed in 2 days. 2 days is all it would take to successfully train a child. And so I just kind of want to give you like the nitty gritty of this. So there's really just 5 main steps. First is you want to only dress the child in underwear, so diapers, no more diapers. The diaper is what we would call a stimulus for having an accident, because the child knows. My 1.5-year-old actually just said this to me the other day. I've been trying to get him to sit on the toilet, and I told him that he needed to go sit on the toilet, and he told me he was going to go to the bathroom in his diaper. So at 1.5, these children are able to discern that, like, I can go into this diaper and nothing's really going to happen. Mommy will come and get me and she'll clean me up or whatever. So no more diapers. They have to be in underwear, and that's really to create the occasion that, like, they're going to be exposed to what happens if you actually have an accident. So if you urinate in your underwear, you're wet, it's cold, it's not really comfortable, it doesn't feel the same as it does when you're in a diaper. Make sure your patients are aware that they should probably have at least 10 pairs on hand that are clean and ready to go, because a lot of accidents do happen, and that's okay. Then we talk about fluid loading. They just load their children up with fluids, juice, water, whatever it may be. Popsicles are really good if they're doing it in the summer, just really to increase the likelihood that these children are actually going to have to go to the bathroom and successfully void. Then we start scheduled sits. And so on the first day, what you would do is just in 15-minute intervals, the child would be off the toilet, and then your timer is going to go off, and then they'll spend 5 minutes on the toilet. Then they'll be off for 15 minutes, and they're going to be on for 5 minutes. So this is pretty intensive. This is going to go all day for day one, but using this schedule, the children are likely to actually have a successful void on the toilet within those interval times. On day 2, we increase the interval because they've already been exposed to this a little bit, and the children will be off the toilet for 30 minutes, and then they'll be on for 5, and so on and so forth throughout the day. And typically by day 2, kids are done. And we've done this a number of times. And I can tell you, like, there are also, like I mentioned, like punishment-based procedures, but this one is all reinforcement-based, and it's highly effective. You also have what we call a potty party. This is where a lot of social praise are delivered, preferred items are delivered when the child actually successfully voids on the toilet. And one thing to point out to parents too is that whatever that child wants to go to the bathroom, just do it, because you want them, again, to be highly motivated, and they should only get that thing for actually going to the bathroom on the toilet. And this could be anything from typical things that are like M&Ms, again, the iPad, that always comes up. I had a student or a child who he only wanted cupcakes with candles in it, and his parents to sing happy birthday to him every time he successfully went on the toilet. Whatever it takes, just do it and go with it. I really, really mean that. And then there is a correction procedure. So if an accident does occur, what we suggest to the parents to do is let their child kind of waddle around in the clothing for about a minute to feel it. And they would say something like, we don't want wet pants, or you need to have, I would actually say we want to have dry pants. You need to stay dry, because you want to tell the child what you want them to do instead of what you don't want them to do. And they would waddle around in that. Then you would give the child or the patient a clean pair of clothes, have them change themselves, clean up the area of the accident if anything was soiled, like on the floor or anything like that, and then go and wash their hands. And the reason we do this is to make having an accident much more effortful than actually just getting up and going and sitting on the toilet and having a successful toileting trip. Then once kind of they clean up, they wash their hands, just resume the schedule as normal. Stress to parents, like, you drop it, you move on. You don't talk about that accident at all. You just continue on with the schedule and keep going. Okay. Are there any questions about that? I put the book that this came from in this PowerPoint for you. I know Troy's pretty good about sending out these PowerPoints for you all, but this came from Azrin and Fox, and it's actually called Toilet Training in Less Than a Day. So there are some children who will pick this up much more rapidly. Other children it will take a little bit longer with, but the average is about 2 days, sometimes 3. Okay.
How old are the kids when they're learning to be potty trained?
So it's going to, this is the bad answer that behavior analysts always give you guys. It's going to depend on the child. So some aren't ready. Like, I have a nephew who's almost 3, and he's just not ready. So I would not try it with him until he's kind of giving me some of those external cues, like a lot of times what you'll see kids doing is taking off their diaper after they go. They'll actually take it off or bring it to mom. And so that's kind of a cue that they're ready to kind of start this procedure and, like, sit, kind of go through this formalized toilet training. Andrea, you could pop in here too with other things that you've seen.
I've also developmentally, like if they're dry through the night, that usually means that they have the capacity to hold. And that's usually a pretty big indicator. Sometimes boys are a little bit more delayed than girls are. So I think because just developmentally, their bladder and everything is usually a little bit later from some of the books that I've read, but I don't know.
Yeah, so those are actually really good points. So if parents were asking me about this, my first questions to them would be, do they take off their diaper when they're soiled, or are they dry at night? Because if those two things are kind of absent, then the child's probably not ready. But if they're there, then they could start this. And again, like as Andrea mentioned, boys are usually a little bit later than girls, and that's just a developmental thing. So typically we see girls trained anywhere from like age 2 to 3, and then boys are probably like more 2.5, sometimes to 4. And I have even heard instances where they may be toilet trained during the day, but they're still having accidents at night, and that's common too. It'll come. Okay, it's a good question though. The last thing I kind of wanted to touch base on was just some strategies for picky eating. I know this is another very common thing. And again, do that physiological rule out, because if there's something, you know, they are like gluten intolerant, or, you know, there's a lot of allergies to dairy, that's totally understandable as to why a child wouldn't actually consume that food. But if not, so what we would do first is have parents make a list of food goals that they want their child to consume. Then we would have a list made of the current foods that the child's consuming and look for kind of any kind of starting points in there. And then there's 2 really different ways that you can handle this. The first is called blending and pairing. And this is really good for all types of food selectivity. So kids who are food selective to color, you see this a lot with children who are on the spectrum. They only like to eat things that are orange or carby. So you see them consuming like Doritos, Cheetos, Cheez-Its. We could go on goldfish crackers. Like they typically will consume things like that. That would be a color preference. There's a lot of texture preferences, and again, we could talk about the kids on the spectrum. They don't like things that are like stringy, so they won't eat oranges. They won't eat things that are like string cheese, that sort of thing, or brand. And my child is even actually, and his best friend are guilty of this. They will only eat Kraft macaroni and cheese, and they know the difference. So if you try to give them anything other than Kraft, they are fully aware of what that is. A lot of kids are like this too with McDonald's chicken nuggets. They will only eat the McDonald's chicken nuggets, and they won't eat any other type. So you have to be really mindful as to whether or not it's just a brand. And what you would do at the blending and pairing is you would mix preferred and non-preferred foods gradually. So starting with just like a little bit of that non-preferred food and mix it in with the preferred food until the child, and gradually increase the amount that you're mixing until they're eating that non-preferred food without the use of the preferred food. This is pretty intensive in terms of food preparation for parents. So that's a caveat. You want to warn parents about that. And this can be done during a meal time, or sometimes we'll even do planned meal sessions with the children if we're coming in actually to the home and helping the parents with this, as to not make meal times aversive for the child. We also would use gradual exposure, and this is really targeting tantruming in response to new or non-preferred foods. And this really introduces the food to the child in a much more slow and controlled manner. So they might just get, let's say we're trying to get a child to eat, a piece of chicken. It may just be like this big at first, and we're gradually going to increase the size of that piece of chicken or the number of bites that they have to consume of that chicken in order to, to work with that selectivity. We would use motivation with each step here. So for every bite that they take, they're going to gain access to either a highly preferred food or some sort of toy, or maybe they're going to get to watch a movie on their iPad for 2 minutes, whatever it may be. But it's going to be based on every time that they take a bite of whatever that is. And again, this can be done during meal times or in some sort of planned session, with a behavior analyst or an interventionist. There is also a book for these strategies. It's called Treating Eating Problems. Again, Fox is one of the behavior analysts that works very highly in the behavioral pediatrics area. And this is Treating Eating Problems. It's specifically geared for children with autism spectrum disorders and developmental disabilities, but these strategies will work with kids with neurotypical peers as well. So you don't need to think that a child needs to have one of these disorders to, have this be successful with them. Any questions on the eating? No? Okay. And so I hope that I've been helpful for you. And I really just want to encourage you, especially as, kind of young residents or med students as well. You guys are all in your third year, that pediatricians and behavior analysts, we really can work more collaboratively. I think oftentimes behavior analysts, we don't do a very good job marketing what we do or who we are. Even some of you may have never even heard the term behavior analyst before, but really we can work in more of like a parallel fashion to maintain and promote child health behavior, because we have strategies obviously that are beneficial to you, but then you guys all have to do all those physiological rollouts and things that we don't have those skill sets. So we need all that done for us as well. So we can work more collaboratively together. And so I want to encourage you to kind of contact us, or if you, if you need help in any of these areas. I listed here some resources for you. And Arndorfer et al., this is an article where I pulled a lot of those, the facts about, children presenting to the pediatric office and kind of the breakdown of a lot of those behavioral issues. I included my name here, my role. You can find me at my email. And then also just a plug, we do have Positive Behavior Support of Nevada. We have a family services program here at UNR. Typically it's a workshop model for various problem behaviors, eating, challenging behavior. We have a toilet training class, but there are a number of areas that we help with. We also, so we do offer classes. We offer in-home consultations. For families, it's important to note that this is on a sliding scale. Some families don't even have to pay to have access to a lot of these courses. And I sent Troy a brochure for the program that we do have here at UNR. So you guys are more than welcome to look at that brochure and contact us. But we also do consultative services just in general. So if you have an issue, if you have a patient that comes in with some sort of issue and you think maybe it's not really physiological and there's something else going on, feel free to call us, because we are, that's what we do. If we work with the families, we typically work in the home, and we would watch all that kind of stuff going on and then keep in close contact with you all so you know what's going on with your patient and their family. Okay, so just some resources for you, so you know how to find us, you know who we are, you know where we are. And with that, I'll leave you with any questions or thoughts.
Thank you so much, Dr. Fernapple. Yeah, we'll open it up for questions right now. Feel free to unmute yourself with the icon in the lower left corner of the Zoom window, or write in via the chat box.
Could you speak to a little, like, at what point you would want to refer patients and their parents to receive or to access your services? Like, do you want them, to make an effort at it using multiple techniques before, or do you want to intervene earlier before it kind of gets to that point?
That's a good question. Thank you for asking. I think, again, it's going to depend on what sort of behavior you're looking at. But if it's something that's going to cause harm to the child, to their family, if it's really intrusive for the family dynamic, I would probably refer them right away, especially if they're little, because it is a lot easier to implement a lot of these procedures with younger children than it is, as you can imagine, with preteens and then teenagers, and as they near more adulthood. It's a lot easier to work with eating habits and things like that with younger children than teenagers. So probably always the earlier the better. That's why there's such a heavy emphasis on early intervention, especially in the realm of behavior analysis. But again, though, if it's a teenager and there's some significant issue, if they're cutting or something like that, and it's really intense, I would refer them right away too. Does that answer your question?
It does. Yeah. Thank you.
Okay. Yeah.
Any other questions today?
Well, thank you all for listening to our little behavioral soapbox. I know it might be some new information, but contact us if you have questions or further questions, or if there's an issue that you just can't figure out. That's why we're here.
Excellent. Thank you so much, everyone, for joining us. So I did send a link out that has our webpage with the slides that were posted for today. And then feel free to poke around our webpage a little bit more. We offer a variety of other clinics. Next week we have medication-assisted treatment, cardiology, behavioral health. We have quite a wide array if you're interested. So we'd love to have you guys back. Thank you so much, everyone, for joining us today.